everybody. This is Chris
and Cathy.
We wanted to take a minute to thank you all for tuning in. We appreciate every listener and are grateful for this platform.
Please help us share our vision by subscribing to our show through your favorite streaming app. Follow us on Facebook, Instagram, TikTok, and YouTube at PetAbility Podcast.
Check out our ever-growing list of affiliates and sponsors. Simply go to the show notes for information and links.
And be sure to use our promo code PETPOD22, that's PETPOD22, on checkout to receive your discount from our affiliates. And now, here's a word from our sponsor.
Hi, I'm Alon Landa, CEO of MedcoVet, and I'm a proud sponsor of PetAbility. We decided to partner with Chris and Cathy because, like them, we want to empower all pet owners who are trying to do the most for their pets. At MedcoVet, we specialize in advanced home laser therapy for pets. Laser therapy is a safe and effective treatment for common conditions like arthritis and wounds, and it relieves pain for most conditions caused by inflammation. With MedcoVet, pet owners can perform this treatment at home while receiving support from experienced clinicians. If you think your pet would benefit from healing at home, visit medcovet.com, and one of our clinical experts will work with you to determine if home laser therapy is the right fit for you and your pet. Tell them PetAbility sent you.
In tethered cord, there is a point where that rope is fixed and we can pull on it from either end and we get to that stuck point.
Welcome to PetAbility. I'm your host, Cathy Symon, certified veterinary technician, certified canine rehabilitation practitioner, and certified hospice and palliative care technician for pets.
And I'm your host, Chris Cranston, licensed physical therapist and small animal physical rehabilitationist.
Our podcast provides interviews and information to help your pets live their best lives.
Hey, Chris. How's it going today?
This topic is a good one.
I have to admit, going into this interview, I do not know very much about this topic, so I'm interested. You've got me. You've hooked me.
Right. It's what I'm going to call a hot topic in our field of physical rehabilitation. And I bet most of our listeners out there have not heard of this. So we are going to be talking today about tethered cord syndrome, or TCS for short. It's a little recognized neurologic condition that may be hiding behind chronic pain, gait abnormalities, weakness, even behavioral changes, or unexplained mobility issues in dogs. So in this episode of PetAbility, we're going to explore this emerging hot topic in our field. Recently, I was on the vet rehab listserv that I often refer to, and one of our professional colleagues called it the tethered cord pandemic. Because, when you get like something that is like, oh my gosh, I'd never heard of this. Could it be this? Could it be that? And then all of a sudden it seems like everything may be that. So it's being diagnosed, more and more, but it's not really a pandemic. That was all tongue in cheek. Anyway, we're going to see what happens when the spinal cord becomes abnormally restricted, how this condition can mimic more common diagnoses, and why awareness is so important for veterinarians, rehab professionals, trainers, and dog owners alike. So joining us is Amie Hesbach, pet physical therapist and rehabilitation professional of over 25 years, educator of pet parents and veterinary professionals in over 10 countries and 3 continents, published researcher, and founder of Empower Physio in 2014. Among many accomplishments, Amie earned the International Association of Veterinary Rehabilitation and Physical Therapy Animal Rehabilitation Professional of the Year Award in 2022. Amie is going to share her insights into recognizing, managing, and advocating for dogs affected by tethered cord syndrome. She is widely known for her work helping dogs improve mobility, strength, function, and quality of life through thoughtful conditioning and body awareness training. Amie has a special interest in complex and often overlooked neurological and orthopedic conditions, including tethered cord syndrome, and is passionate about educating both professionals and dog owners on the importance of recognizing subtle movement dysfunction before it progresses into larger issues. Now, you may recognize her name because she was a previous guest on PetAbility discussing neuroplasticity in November of 2021. So that's been a minute. Neuroplasticity, How Experiences Rewire the Brain for Healing, was the title of that previous episode. And today we welcome back with great enthusiasm, Amie. Welcome back, Amie.
Amie, I don't know if the rest of the audience knows this, but Amie and I were in the very first graduating class at the University of Tennessee for canine rehab. So we were the first of the 36 canine rehabilitation practitioners that hit the ground running in 2003. Amie can correct me if I'm mistaken. I think it was 2003. So I'm always excited to hear what Amie has to say. She's a pioneer in this field. So welcome back to the show, Amie.
Thank you. Thank you so much. It's great to chat with you both. And I guess the other connection is that we all live in the Boston area. So,
Yes.
yeah, it's a great place. And, you know, the UT program and the CRI program that I got both of my certifications through, I think gave me a couple gray hairs. Definitely got me started on that path as well. But here we are, you know, still plugging away and learning new things every day. It's been a great journey.
Well, and Amie, even though we're all three in the Boston area, we never see each other. I think the last time I saw you was when you returned from, the Netherlands. And another commonality between you and me is that we're both physical therapists in this field. So that's somewhat unique. Yep.
It is.
Yeah.
Quite unique. Yeah. But it's been a lot of fun. And actually this topic is a great connector, because when I heard about tethered cord, I thought, well, okay, I worked with kids with that, and I've met adults with that, but never a dog with that. So it definitely got me thinking and got those wheels turning in my brain again. So yeah, so definitely a hot topic, definitely the latest and greatest, or maybe not so great diagnosis out there, but we're definitely getting more inquiries from pet owners, from trainers. You know, you do a search on the internet or even on Facebook, you find tons and tons of groups devoted to the subject. It's definitely an interesting topic, and I can't say that I have all the answers, but I've definitely gained some experience.
Remember, what was it, about 10 years ago when every dog had an iliopsoas injury? It's like, we'd never heard of we knew, you know, but that all these dogs had iliopsoas strains, but did they? And chicken and egg kind of things, you know, is it secondary? Is it primary? And, you know, this is, I've never even heard of it, Amie, in the human side, but I know, you worked in neuro and pediatrics and so forth. And I didn't, you know, I was all sports medicine. So
yeah, the funny thing is all those iliopsoas dogs that we saw, I'm like, oh, were they all TCS dogs? So yeah, it comes full circle, you know, so it's very, very interesting. Yeah.
Good question. So let's get to it for listeners, you know, who are not familiar with tethered cord syndrome. Can you describe it? What is it?
The best analogy is like a tug of war. So if you think about the nervous system, the spinal cord, the nerves, as being somewhat rigid, but also somewhat flexible, like a rope. And there's tension on that rope. If we pull one end, we're effectively pulling everything attached to that rope. In tethered cord, there is a point where that rope is fixed, and we can pull on it from either end, and we get to that stuck point, maybe a knot in the rope or a place where it's fixed to an immobile thing. And that creates more tension, it creates pain, it creates potentially inflammation, and all these crazy signs that we see in dogs with this disorder. So it's the actual tethering is within the meninges. So it's located in the area of the phylum terminale. So we have to really, we need to do a Google search of spinal cord anatomy in the dog, right? And really remind ourselves of the different pieces. So you have the spine or the vertebral column. So those are the bones, right? Mm-hmm. And then within the spinal column, you have the spinal cord. So you have the nervous tissue, and then you have all the little nerve roots that are exiting the spine and innervating everything in the body. So the end of the spinal cord is called the conus medullaris, and that is where it narrows, it becomes kind of cone-shaped. And normally in dogs, it ends, or that point is around L7. So in smaller dogs, it's actually more distal, so closer to the sacrum. In larger dogs, it's more proximal, so it's maybe around L5, L6. But then surrounding the spinal cord and protecting it, we have the meninges. You have the dura mater. Oh, here I am with my Boston accent. The dura mater, pia mater, the arachnoid layer. So in the area where we have the conus medullaris, we have what's called the filum terminale. So the filum, and that is where the tethering happens. So this is kind of a band. It supports the spinal cord at the caudal points. It's an extension of the pia mater, and there can be adhesions within that area. So the meninges are connective tissue. So it's really, really an interesting topic, to be honest, from an anatomical perspective, biomechanical, neurological, orthopedic as well. In that, this is a meninge or part of the meninges. It is a supporting structure. It's fibrous and supportive, but it's also somewhat elastic, and we can have adhesions. And I think part of the reason this is such a hot topic is that when these adhesions are released, potentially surgically, there can be the potential for what's called retethering or readhering of this area. One thing that hasn't been explored extensively, and I'm not going to say that it hasn't been explored at all, but not extensively, has been more conservative management of these cases, in that, if we're doing potentially fascial release in human patients, they use shockwave therapy, maybe even craniosacral therapies. And I know a lot of these are maybe questioned in the scientific literature, but, again, we haven't explored all of these avenues of treatment. So we see this adhesion in the distal spinal cord. And so when the animal moves, there's tension on the spinal cord, there's tension on the meninges, and that creates the pain, the dysfunction, the lameness, the neurological dysfunction, and so on and so forth. You mentioned behavioral changes, and a lot of these dogs are identified by trainers initially because the owners are noticing behavioral issues, anxiety. Some of them, actually most, I would say 75% or more pet owners are going through this huge circuitous route to get an accurate diagnosis. So they're seeing orthopedists, they're seeing neurologists who may be unfamiliar, they're seeing trainers and behaviorists, they may be seeing rehab professionals and physical therapists. And so awareness on our part is really important, that we add this diagnosis or this syndrome to our rule out list, that we're evaluating and reevaluating these cases. And when they don't look like they actually fit in a diagnosis that we're familiar with, that we may need to explore this a little further.
Amie, is TCS a congenital malformation, a developmental, or is it a traumatic? Because as I'm thinking, if these dogs are born with it as they grow, right? Can you imagine the tension that's put on that as the animal grows?
Exactly.
Do we know what the cause of this is?
So it's associated with some congenital issues and some that are developmental. So it's associated with Chiari malformation in people, Ehlers-Danlos syndrome, spina bifida, meningomyostele. So there is some evidence that developmentally, and like you were saying, as the vertebral column grows, something is actually happening and something is causing this cascade. I'm not so versed in compartmentalizing, specific breed dispositions, But, I think as we're identifying more and more, we're probably going to be seeing more breed disposition, more like body size associated with this condition. I think that the awareness is maybe predisposing us to looking at like border collies, for example, some smaller dogs, some dogs that have either have absent tails or docking of tails where they may be predisposed. But I think the verdict is still out because it's still so new and newly recognized, and we're gathering more and more information. I think one of the other concerns is that I wouldn't say that we're maybe overdiagnosing it, but what does the phylum Terminale, what does the conus medullaris look like in normal dogs or asymptomatic dogs? So our neurologists, our veterinary neurologists are doing this dynamic MRI on symptomatic cases to rule in or rule out TCS. But we're not, or at least I'm not aware of them doing this dynamic MRI on normal dogs or dogs that are not symptomatic. So I think too, the training profession and a lot of our sporty dogs and trainers and handlers and owners are more aware of this. And so I think we're seeing more of those people fully pursuing this diagnosis. And again, it's for most of my clients, it's been a long journey. They know a heck of a lot more about this than I do based on their years of experience and going through diagnosis and diagnostics through multiple specialists over time. So again, very interesting. And I think if we revisit this topic in another year, another 2 years, we're going to know so much more. And we may be suggesting that, some of these things are untrue. So I think the future will surely tell, whether surgery is the only answer, whether rehab can be beneficial in a conservative management process, or, what the solution might be.
When you were talking about some of the conservative treatment options, and you mentioned myofascial release and so forth, one of the things that I thought of, but it may not work at all, is neural mobilization.
Mm-hmm.
So
yeah, that's a big part of it. And I will tell you, there's controversy wrapped in and out and through and above and beyond this topic. But yeah, that is definitely a component of rehab. The concern is neural or dural mobilization, we know can be harmful if it's taken on too aggressively, or it's taken on by untrained hands. And think about, you and I as physical therapists, when we're doing this with our people patients, we get feedback from them. They let us know what it is they're feeling. We can check in with them as we're going through this process, this manual therapy technique, and we can be as conservative as we need to be. Our animal patients, yes, give us feedback, but they're not going to help us to discriminate between, oh, I feel a stretch in my hamstring, to, oh, I feel a zinger going down my leg to my foot. Now my foot is numb. And so that's certainly a bit of a concern. One of my thoughts on this process and using these techniques is that if we're applying it too aggressively, yes, we can cause further harm. Can we apply it conservatively, or is that going to be harmful as well? How stiff are these tissues? How severe are these adhesions? As we're going through the process and our neurosurgeons are releasing with a surgical procedure, what's really necessary and what can we actually do with our hands and treat? So I haven't been able to get my hands on too many that haven't gone the route of surgery, but certainly dural mobilization is part of the treatment. But we have to clear the other tissues first. We have to make sure that the joints have full range of motion. We have to make sure that the muscles have good flexibility before we can start to put tension on those neural tissues. Yeah, so it's definitely part of the process, but I think we have to be really cautious about it. And also, we don't know the answer as to when to apply this. If we're applying it too early, too aggressively, could we potentially stimulate retethering or readhering of the tissues? Or if we're not applying it early enough, has that readhesion happened already? Or have we kind of lost, where is that window of opportunity? Somebody had mentioned, I think online, like just treating the patient in front of you, treating the dog in front of you. And yeah, that's very true. I think, we always have to assess and reassess and structure our rehab program around that individual patient, but also, exploring all the options. It's tough, and working together with that team. I mean, the pet owner is with the dog almost 24/7, or they're very observant of the signs that they're seeing. And, we can't, as physical therapists and rehab practitioners, we can't see them 24/7. So we don't know how they're responding and when they're responding to these techniques. So, but there is a lot that we can do, I think, with regards to exercise and movement retraining, even modalities and things to give these guys some relief. But again, it's the awareness of the anatomical problem or the biomechanical problem that is going to really help us to develop a good plan for these guys.
I'm thinking about all the patients that I saw that have similar conditions that mimic, and my IVDD patients, my lumbosacral disc disease patients, even my hip dysplasia patients, right? Is there anything we should look for in movement patterns or gait abnormalities that might raise a red flag for us and go, okay, this should be on the table, and we should bring this to the veterinarian's attention? Maybe this is a differential, or maybe they exist together. Maybe IVDD and hip dysplasia and TCS exist simultaneously. They exist together.
Yeah, I think we definitely have to rule out a bunch of different things and also consider that there could be additional diagnoses. It's trying to figure out what the primary one is. But yeah, there's a laundry list of signs that go with this syndrome. But I would say, as a physical therapist, what I notice is that these guys have a really hard time sitting with pelvic tilt. So they tend to sit with like a caudal pelvic tilt. So they're sitting back on their sacrum, sitting or even lying in a sternal posture with extension of the lumbosacral area is really tough for them. So I see that. I see issues with these kind of paresthesia behaviors. So kind of like that eye that's not there, that's bitten their butt, and they flick around and they look at it and they're like, what's going on? Or maybe they're doing some like kind of chewing or nipping or licking kind of in one specific area around the groin or around the gluteal area. They may have this kind of weird kicking behavior with one leg. But I think, one of the things that I think is really enlightening are these weird gait deviations where they're doing kind of a skipping gait in a transition, where it might look like an MPL or a patellar luxation dog. It might look like a happy jack skip. They may be able to rule out MPL. They may be able to rule out any cruciate ligament issues, but they have this kind of funky gait dysfunction that doesn't fit orthopedically. It doesn't really fit neurologically. So I think the dogs that have significant TCS issues are pretty darn obvious because they fit all of these different criteria. It's the ones that are so subtle that are really tough. They kind of resemble the LS dogs and they're younger, right? So like LS, we usually see in kind of middle to older dogs, the LS dogs, but at a younger age. So sometimes like 3 or 4 years of age. Some of them will have bowel and bladder dysfunction, and they will have difficulty like completely eliminating. They may have a higher risk UTIs. They may have incontinence. So that can be associated, as can like kind of tail weakness. So if they don't have strength around the tail, then they do tend to scoot, or they tend to like kind of walk as they're defecating. So that can also come into play.
Okay, I've diagnosed Baxter again. Every podcast we have, I'm like, he has a rounded top line. He sits with caudal pelvic tilt. He has had bowel issues his entire life. He walks when he defecates, he scoots, he but doesn't have any anal gland issues or anything like that. And recently he has started to have urinary incontinence when he sleeps.
Wow.
And when he was a puppy and I would attempt to cuddle him, he screamed out. That seemed to resolve as he matured. But I think I probably was trained to not put him in that position, subconsciously.
Yeah, so it does make me wonder too, like how many dogs with, like lumbosacral disease or propensity to that, or transitional vertebrae, and is the TCS the cause, or is it the result of, this chronic positioning and posturing, right?
Yep.
One thing that's kind of interesting, I don't know if you remember way back when kind of studying spina bifida in kids, and kids with spina bifida might have like a little dimple over the lumbosacral area or over the area where the spine is malformed. So the neurologist that I've been working with very closely in these cases, she has suggested that a lot of these dogs have changes in their hair coat. So like the fur is going in one direction and then it turns, or they have like a little dimple when you clip the fur coat. So they have that, what I think about as a fascial adhesion, even more superficially. So really kind of interesting stuff that we're learning about these guys.
When I was reading about it before we got on the air, and the information was sparse actually, but one of the breeds that was suggested that may be at higher risk for TCS is the bulldog. And if I think about the base of the bulldog's tail, right, when you look at it, it's bizarre, right? It's bizarre, and sometimes it's dimpled, and sometimes the hair is growing the other way, and sometimes that tail is sort of maybe even a little bit inverted. So yeah, it kind of makes sense, doesn't it? That might be a breed that you might see with Tethered Cord Syndrome.
Absolutely. I wonder too, I know I work with a lot of owners who are very involved, and they have a lot of different clinicians involved in the care of their pet. So they may be seeing acupuncturists, they may be seeing body workers and massage therapists, they may be seeing chiropractors and me. And how much are we seeing or feeling that we're not always putting a label on that is different, right? Like maybe not significant, but different. And so, when I put my hands on my patient, I've done some kind of fascial training, and I always roll the skin, just kind of lifting and rolling it along. And I always kind of hone in an area where there's less ability to roll or to pull at the skin. And so I attribute that to more superficial fascial restrictions, but then I wonder, is it reflective of something deeper? And I suspect it. Now it's when I see like these 8 or 10 different signs, and I have that checklist, and I see 6 out of 10 with a dog, then I'm, maybe getting on the line to Dr. Parsley or another neurologist that I know, and asking them more questions, or talking to the owner about like different pain behaviors that the pet might have and other things that they might be noticing. Again, bringing it back to kind of that rehab perspective of quality of life and comfort and, functional abilities. Like, are these signs impacting their quality of life? Are they impacting their functional abilities? Is it getting in the way of them leading a full and healthy life? Or is it something else? And I feel like we need to rule out a lot of the simple things, the easier things first. The neurologists that are doing these untethering procedures, they're doing a lumbosacral or a dorsal laminectomy as well. So a lot of these dogs that have DLSS or lumbosacral stenosis, how many of them also have TCS? I'm not sure, but I think that our neurosurgeons are probably managing that tethered cord while they're managing the lumbosacral stenosis and vice versa.
Amie, are you insinuating purposefully, intentionally, or because they're going in and doing these, laminectomies, that it is inherently addressing the tethered cord syndrome at the same time?
Yeah, that's a tough one because I'm not a neurosurgeon. So kind of I'm looking at my caseload and these dogs. I wonder a lot of the signs with lumbosacral stenosis resemble those of TCS, but I think that TCS is maybe a little more specific. I'm certain that lumbar dorsal laminectomy is probably done more often. Actually, I'm certain of it. It's done more often than a TCS untethering procedure is done. But I wonder how many of those dogs that are having purely a laminectomy are that untethering is happening. I don't know about consciously. I'm not sure about the actual procedure itself, but are we addressing both at the same time?
Right.
Yeah. So again, the chicken or the egg, and where are we addressing these things? Historically, as a physical therapist, I never really loved working with these lumbosacral dogs because I felt like after surgery, I was managing their recovery from surgery, but also the lumbosacral disease. And a lot of times they were more chronic. And again, it's a more peripheral nerve issue than it is more central with regards to IVDD. So they can be a challenging group. And I know some of the research has shown that, with a dorsal laminectomy or conservative management with like conditioning and rehabilitation, the outcome may be very similar. Again, PT and rehab is not widespread enough, nor is it uniform enough for us to make a lot of comparisons. I think that's a challenge that we have within our field.
Well, and just to bring it back, we are simply the purpose, I think, of having you on the show today and discussing this topic is just to increase that awareness for the 60 million, pet owners out there, which then brings me to the point. I mean, we're just starting to realize that this is in dogs. Why can't it be in other species?
Yeah, and I'm sure that it is.
Like,
right?
I was thinking about the Manx cat, right?
It's been documented in the Manx. Yeah.
Yeah. Yeah. And I, again, apologize because my lit review has been fairly limited, but I agree. Like those that have tail abnormalities, whether at birth or, surgically docked or altered or genetically altered, how much of that is reflective of TCS and, other issues that we have. Even our dogs that have incontinence and we think about it being spay incontinence, it's like, okay, well, yes, but, so what else is going on?
Or yes, and, right?
Right. Exactly. It's the yes, and the or. So again, it's one of those diagnoses that I think we add to the list. We investigate a little bit more. We learn about it more from those that have been positively diagnosed and those pet owners kind of following their journey. So it's very interesting to talk to them. I always found it fascinating learning about different breeds, learning about different dog sports through the owners. And this is one of those diagnoses that I truly am learning more from the pet owners than I could probably learn in any textbook or any veterinary journal right now.
Yeah. It's always pushed by the pet owner. We
Absolutely.
It's always pushed by the pet owner, which is good.
They know their pet.
Exactly, which is good. I'm glad that they do. But, I'm kind of thinking as we talk about this sort of functional impact and quality of life that we were discussing previously, and how I'm always interested in the emotional lives of my patients and pets, and how this condition may affect their daily life and their confidence and their behavior. And maybe they can or they cannot go back to their sporting activity. Maybe they can or cannot go back to hiking, and how that weighs on the dog and how it weighs on the owner too. And that there's some breakdown sometimes of that human animal bond when we have a patient that has this type of condition where they can't do or engage in the kinds of things that they do together with their owner. What does long-term management typically look like for these owners?
Oh gosh, yeah, that's a really good question. So I would say I've had a client who's at least a year out. Some return successfully to sport, some return to normal activity again. A lot of them are being managed for pain on pregabalin, for example, for at least a year. So the medical and the surgical management continues for a good long while. I think there is the ability and the capability for them to get back to normal activity again. What is normal and who defines that? Normal movement and function versus normal quality of movement and function. Those are two different things. So maybe because I'm a bit older as a physical therapist and I've learned a lot about recognizing comfort and discomfort in my patient, and I'm not going to say pain or the absence of pain, but comfort and discomfort, is that I'm a bit more respectful of that. So educating pet owners with regards to how their pet is moving, why their pet is moving that way, why they're choosing a specific posture, why are they avoiding specific activities, why they are like licking or chewing, and is this normal or abnormal? A lot of it is educating them with regards to signs of comfort or discomfort and those really subtle things. It's not just the pet crying out or screeching, but a lot of these kind of subtle movements and changes in their postures and changes in their behaviors really change things. Some of these dogs that are so involved, they have anxiety. And, here we're coming down from the pandemic and a lot of dogs being adopted into homes that have never had a pet, and dealing with the anxiety and the social isolation and the lack of ability to do like training or socialization of these pets. A lot of pets having anxiety, whether it's associated with other, medical issues or not. Anxiety is part of this as well. And so piecing through it all is so challenging. And I'm not a psychotherapist, but, we're working with people all the time. And it's like how much of the owner's anxiety is reflected on the dog and how much of the dog's anxiety is reflected in the owner. And, and is it environmental? Is it movement-based? Is it food sensitivity? Like there's so many things that are coming into play. And, so that's when I kind of pull away and put myself back in that physical therapy box and put the blinders on and focus on the things that I can control. So, but we do have to consider so many of these things.
And now that I'm convinced that Baxter has it, he also has anxiety.
Yeah.
He's been anxious his whole life. He takes the things to calm him down. And so it fits, right? And this is, again, that warning to all of you out there. We want to increase awareness, but also don't go to Dr. Google and, again, try to put your pet in a box that may or may not fit. Awareness is one thing, and teasing this out and seeking professional help. But, we're all guilty of that, I think, for ourselves. And we certainly don't want to project that, on our pets. And earlier in the conversation, you said sometimes this can mimic like an MPL or medial patellar luxation. We just published a show with Dr. David Dicus about that topic, but it made me think of this mini schnauzer that I treated a long time ago. And he was very healthy, seemingly, aging well, had a great quality of life. And when he would go uphill, he would skip. But this luxating patella had been ruled out multiple times by boarded orthopedic surgeons, couldn't find, anything wrong. And I wonder if that, in hindsight, could have been a sign of tethered cord syndrome.
That's so interesting because, when you're going uphill, if the head is up, the spine is more extended, and that's where we tend to see more of these issues. So when the back is flat or the pelvis is tilted cranially, when there's more extension, they can be more symptomatic. And so when they're climbing uphill or walking up a ramp, we're asking for full excursion of the sciatic nerve, so they don't recognize sciatica in dogs so much, but I think that's something that pet owners and just people in general can understand. How these different postures and movements can really elicit more of that sciatic pain in these guys. So,
and the point to the pet owners out there too, don't think it's silly or your imagination or again, this is driven by your observations, and trust your gut and bring it to the attention of your dog's healthcare team, because it could be just that thing that sheds light and somebody has that aha moment. And, sometimes maybe there's not a lot to be done, but that knowledge is power. And, just knowing, again, maybe in this dog, it could have been zigzagged up hills or a ramp to lessen that amount of extension required for him to go up a steep hill. And that skip being a result of trying to, maybe shorten that stride to limit the amount of extension. So back to your point, Amie, where the gait may be different, but he's taking care of himself such that it's not causing him great discomfort. He knows that, if I just skip here, then I'm not reaching that point of discomfort, I guess, and alleviating himself. So that's okay. He's taking care of himself. I mean, it happened once in a blue moon. So not to perseverate on these things and trying to create ideal or perfection, because there's a reason for these compensations.
Yeah, I love the point that you're bringing up, and it really resonates with me because, here we are, at least in the U.S. and probably across the world, we're in a trying time economically. Pet owners want the best for their pet, and they see these signs and these symptoms, and they think, I need to go out and get a dynamic MRI. My dog needs this untethering procedure. This is going to cost me $20,000, $30,000, $40,000. Is that really practical? Or in some of these milder cases, can we manage them conservatively? Can we respect their boundaries and their needs to compensate? And I feel like this is where we as rehab professionals, as physical therapists, we can really help to counsel pet owners and work together with them to devise a plan. Here are activities that you want to restrict 100%. Here are activities that you want to be cautious of. Here are things that when they have a flare-up, we can do to help. I found that so many of these dogs, for one reason or another, whether pre or post-operatively, they seem to really like pulse EMF, so pulse electromagnetic therapy. Can we use that in combination with medical management to make them more comfortable, keep them mobile, keep them comfortable, keep them functional? I think that it's a yet unexplored area, and I'd love to see more of that being publicized and talked about and shared amongst pet owners as well as our colleagues as well. We want to avoid surgery if at all possible, but avoiding it in appropriate cases. So when it's really impacting and impairing their mobility, their comfort, and we've grabbed the short straw and we have no other option, then sure, we're going the route of further diagnostics and potentially surgery. But we're not going into that blindfolded, because this is an extensive recovery. I think activity is really restricted for at least 3 months, if not closer to 6 months post-surgically. And, there's always the possibility that they retether. It's not common, but it does happen. And we're back at square one. And that's really frustrating.
Oh, and can you imagine that you just spent, thousands.
Holy cow, right? Yeah.
Thousands just for the MRI. And I think sometimes in cases like this, I'm like, well, I know that we have the ability to do that, but should we? We could, but should we?
Something that I say a lot is, yes, we can, but should we?
I counsel people on, is that diagnostic test going to change your course of action? Is it going to help you in your plan with your pet? Because many people will tell me, well, no matter what the MRI shows or the CT shows, I'm not going to have surgery. I don't want to put them through that, and that's their, decision to make. Then why have the MRI? I mean, I'm assuming dynamic MRI in my brain, that's like, they're being MRI'd while they're moving around, but they're still sedated. And I'm assuming that the people are moving the dog passively in the MRI to then come up with that diagnosis. Is that true?
I would say yes and no. So they are moving them passively, but then they're doing the MRI in a flex position, in an extended position, in a neutral position. So so they're actually immobilized in those different postures while they do the MRI.
For the lay person, when I, again, playing devil's advocate, when I hear dynamic MRI, they may be imagining, oh, my dog doesn't need to be sedated or anesthetized for this procedure because they're moving around and then they're looking at them in this imaging. But I just wanted to be clear that that is not the case.
That you are correct. Yeah. So they're sedated or anesthetized. They're going through this MRI procedure and it's more extensive. It's longer. And I don't think that we're at the point where they're going directly from MRI to surgery. So they're doing the MRI, they're analyzing the MRI, discussing things thoroughly with the pet owner, and then scheduling the surgical procedure. So there's 2 anesthetic events. It's pretty extensive. I appreciate the need for diagnostics, if anything, to give answers to the pet owner, and what are we really dealing with, and then being able to make the decision about surgical management or otherwise. If TCS is diagnosed and it's not so severe, the symptoms are manageable, but then the symptoms progress, then we already have that information and that diagnosis, and we know what route we're going to take, what path we're going to follow. It's maybe a little more cut and dry, a little more simple with a cruciate ligament rupture. You can do a cranial drawer test or a tibial thrust test, and you can see and feel the instability in the knee or the stifle, and you don't really need an MRI to define that. With TCS, there are some dogs even who do this dynamic MRI and it doesn't definitively show that they have TCS, but they have all the signs and symptoms. And this is a group that they call occult TCS, where when they actually get in to do surgery, that's when they see those adhesions. That's when they see that immobility of the spinal cord. But their MRI is not definitive. So that's going to just make people that much more frustrated, to be honest. It's like you spent all this time and energy on an MRI and you still don't have answers. But, that's when we're looking at not so much AI and Dr. Google, but, the professional knowledge and experience and skill of our neurosurgeons and, leaning on them to help us make the plan.
You don't want to be the one where the neurosurgeon says, this is a really interesting case.
Right. Time I pause and I say interesting, I see the hairs being raised on everyone's neck. That's not the comment you want to make as a medical professional.
No.
And bringing it back to rehab, if we're treating conservatively or not, like you said, it could be post surgery, but they still maybe have some changes in movement and such. That's where we shine in our ability to recognize and treat the compensations. And I cannot state that enough, that again, maybe we let the primary gait abnormality go because they're doing it for a reason, but how do we address those compensatory changes and keep the dog as comfortable, moving fluidly, etc. thereafter, right?
Yeah. I think, this is kind of my bread and butter right now, like seeing so many dogs with compensatory issues, whether it's a shoulder tendinopathy or so on and so forth, and evaluating and seeing them and managing this issue, but then finding that that's not the primary issue. How many years or months of compensation has this pet gone through to try to make themselves more comfortable? And so me as a physical therapist, as a rehab professional, I'm actually managing those secondary issues first and chronically, because the pet is always going to compensate. They are always going to move in a certain way. And we've got to try to preserve and keep them on all fours, right? So it is, for many of my patients, I have a lifelong relationship with them and with their owners. Not that I'm treating them twice a week, 52 weeks a year, but that, they have me on speed dial and they have my email and they reach out to me, when times get tough. And, we work together as a team with their primary care vet, with the specialist to help them to manage the greatest issue in their lives at that point in time. And it may be compensations, it may be TCS, it may be something else. These guys they're so good at hiding and disguising significant issues. It's really remarkable. And I won't even compare them to the human patients that I see.
I was just thinking that, Amie, if I came in, I'd be like, oh, this hurts and that hurts and everything hurts. I would be emailing you every day. I know, it's amazing. They're amazing. And, I have a couple of patients who have pretty significant either limb deformities or progressive diseases. And they're like, okay, these are the bodies that we were given and we're just going to work with it. And they don't complain. So they're always amazing. And I'm complaining all the time about the body I was given. It's not tall enough. It hurts all the time. Right. So it's amazing. Yeah.
I was just going to say, and going back to the anxiety, if you've been following the show, I had knee surgery for arthritis in early March. And I guess technically it's kind of chronic pain, but it's only been, months. And because I had pain before I went into surgery, but how that messes with your mind. So again, anxiety, depression, I got to give it to our pets. Again, they can't talk to us, but man, they just want to eat, sleep, be able to be, somewhat mobile and be loved, and, good for them.
We should adopt that model of living.
Goes back to movement and movement healing and movement releasing endorphins and movement just making us feel better. We went through a rough winter here in Boston, right? And it's just, getting outside and moving and seeing the sun, and all of these things have such an impact on our well-being, on our mental health, but also our physical health. So getting ourselves in a good headspace and a good place physically can, help us to help our pets too. And I see so much frustration in pet owners who are trying to find answers for this real pain, this real dysfunction that they're seeing in their pets, these real behaviors. And again, it's that awareness and for us kind of being frontline evaluators and really raising that question of interesting. This is not something I've seen before, or this is unusual, or maybe we need to pursue further evaluation or diagnostics by a specialist. So I hope that's helpful to your listeners. It's really kind of raising that awareness, and not so much alarm bells, but awareness and education is important.
I want to emphasize that as far as I know, I haven't looked into it recently because we're learning more about, our dogs and our pets all the time, but they don't fake stuff. And so when a pet parent will tell me, I think he's just doing it for attention, he's faking, or when they're limping, they're like, but they're not in pain. And I'm like, well, they're changing their gait and have a lameness again for a reason, maybe it's to avoid discomfort. So this is, a real condition. We're learning all the time, and we're just at that very, very tip of the iceberg when it comes to tethered cord syndrome.
Right. Amie, thank you so much.
You're welcome.
It's always enlightening. I'm just reviewing all my patients I've had for the last, 20 years now going.
Me too. Oh my God.
They have this. So, but in any case, maybe you could let our listeners know, where can they find you?
So easiest is by email. My email is amiehesbach@gmail.com. It's AMIEHESBACH@gmail.com. My website is Empower Physio Pet. That's OWERPHYSIOPET.com. And there is contact form on there. I definitely keep up with those as well. So yeah, so I really welcome anyone by email or through the website. They have specific questions. I'll be happy to help.
Do you do virtual consults too, Amie? I'm not sure.
I do virtual consults. I really feel very strongly about connecting pet owners with skilled rehab professionals in their area and professionals who understand this syndrome and the need for, kind of a regimented protocol, but a very individualized protocol for them pre and post-operatively or in a conservative way. So I'm happy to connect with pet owners, connect them to rehab professionals. I'm also happy to help rehab professionals, as they're exploring this diagnosis and seeing different things in practice. Yeah, so they're more than welcome to reach out to me, and I'll do my best to connect you with someone with boots on the ground. I think when we get into, more individualized kind of focus times, it's better to connect with someone one-on-one by Zoom. And, you can tell a lot through like videos and history, and as we're seeing these kind of patterns changing. But I don't want to step outside my bounds because, again, hands-on and face-to-face interaction, you really can't beat it, especially with something like this.
Excellent. I encourage you to reach out to Amie, go to her website, listen and learn everything you can from Amie. She's always on the precipice of new and exciting things. So thank you, Amie. It was a pleasure to have you as always. I hope you come back.
Thank you.
Thanks, Amie.
Absolutely. Thank you guys so much. And we'll have to get together in person someday soon.
I'll believe it when I see it.
Bye. You.
All right. We'll see you. Bye-bye.
Thank you for joining us. We hope you enjoyed our show.
Follow us on social media at PetAbility Podcast.
And please check out our affiliates and sponsors.
Simply go to the show notes for information and links.
Thank you and tune in next time.